guests. I've been privileged to discuss the 4 abstracts you've just seen. I entitled this talk, EGFR Tyrosine Kinase Inhibitors, a Treatment at its Maturity. It's just about 15 years since these drugs first entered clinical trials, about 7 years or so since we first learned of the occurrence of EGFR mutations, and I believe that this therapy, partially on the basis of the 4 studies that we've seen today, has now reached its maturity in its use and its clear role and its limitations in the treatment of advanced non-small cell lung cancer. So these are the 4 studies that we're looking at, Optimal and EURTEC, the Korean study groups, and Titan, the first 2 in frontline therapy and the second 2 as second-line treatment. So EURTEC and Optimal are very similar in design. They are first-line studies only in EGFR mutation patients, and they really answer, along with 2 other trials, fairly conclusively the role of EGFR TKIs in frontline therapy, both essentially identical design of comparing themselves to platinum-based doublets of various types, and both achieve their objectives in terms of progression-free survival, and importantly, with a favorable spectrum in terms of toxicity and where measured quality of life in comparison to standard chemotherapy. So where do these trials stand up? Well, if one compares Optimal and EURTEC in red, the current trials, with the 2 prior trials from Japan, also in EGFR mutated patients, one finds a fairly consistent set of results in now what is getting close to about 750 or so patients, with PFSs of approximately 9 to 13 months, and overall survivals were reported of approximately 2.5 years. Again, in all cases with favorable toxicity in comparison to standard chemotherapy, and again, we're measured superior quality of life.
Next.
So where a decade ago we would have a choice of a platinum from column A and 1 non-platinum from column B, we now have a much more sophisticated view of the world. And I think that in non-squamous carcinomas, where did it go? There we are. Those with EGFR mutations, which should now be obtained in a fairly standard fashion, approximately 40% of patients, their first-line therapy should be an EGFR tyrosine kinase inhibitor initiated at the earliest possible opportunity. And as one can see, we now have a variety of selections of treatment based upon both histology as well as clinical status for the remainder of non-small cell lung cancer as well as with squamous carcinoma, with in all likelihood a second highly targeted therapy for the small EML4 ALK translocated population, likely to be approved later this year. So clearly this has come a long way in the last decade, and EGFR TKIs have now entered the front ranks of therapy for non-small cell lung cancer. So let's move on to second-line treatment. Second-line therapy has become established in non-small cell lung cancer, a concept that would have been almost laughable 15 years ago, based first on randomized clinical trials showing the superiority of chemotherapy agents, of chemotherapy docetaxel specifically against observation and erlotinib against placebo, and then the demonstration of docetaxel versus pemetrexed of essentially equivalent agents with a superior toxicity profile for pemetrexed, and in Gefitinib versus docetaxel, the interest trial of essential equivalence there with a favorable toxicity profile for Gefitinib. And I will spend some time particularly comparing interest with the current studies. So first, I'm going to take slightly out of order the study we've just heard from Korea. This was an adenocarcinoma in an enriched never-smoking population, and compared pemetrexed versus Gefitinib. This is the first time we've seen this comparison, with a superior progression-free survival for Gefitinib, but similar overall survival, a very common event in these populations due to the crossover. What I found somewhat surprising was the advantage for Gefitinib in both the mutant and wild-type populations, with pemetrexed having a somewhat poorer response than one would expect, even in an unselected population. So in the original study of pemetrexed versus docetaxel, the PFS was 3.4 months, and so considerably better against docetaxel, and somewhat surprising. Even more surprising is the fact that EGFR mutations and perhaps EML4 ALK translocations have been reported by some, though not all, to be predictive indicators for beneficial response for benefit from pemetrexed. So here, a study recently published in lung cancer by Dr. Wu, and another one by Dr. Kamich in the Journal of Thoracic Oncology. One would have expected that this population of EGFR mutations in EML4 ALK translocations would be enriched in a never-smoking population. And so I would have expected, if anything, for Pemetrexed to have a better PFS than we have seen. So that's somewhat surprising. And one would like to see certainly thymidylate synthase levels reported upon, since obviously tissue is available, because there's something I think a little bit amiss here as far as the activity of Pemetrexed in this population, or at least surprising.
Next.
So that brings us to the issue of biomarkers, and we certainly have 3 established biomarkers now in non-small cell lung cancer: histology, EGFR mutations, and EML4 ALK translocations. Titan was a little different than other trials in this, in that it used chemotherapy refractory patients, those who actually progressed on therapy, and therefore should be compared with INTEREST, which had a population that included sensitive as well.
Thanks.
So in Titan, as we have learned, tested erlotinib versus chemotherapy in a refractory population. Not shown this afternoon was the progression-free survival, and normally I'm somewhat of a critic of PFS. However, I think that that's probably the most informative thing when one is looking at the activity of a single agent, and particularly for biomarkers. And in both situations, the PFS, and this was taken from the presentation at ESMO, is less than 2 months, and therefore essentially both arms are in fact inactive. And I think it's very difficult to show that a biomarker will be of benefit or not of benefit when very few patients, if any, actually benefit from either of these approaches.
Thanks.
So let's look again versus INTEREST, and there were virtually identical results for both of these, and this sort of shows you the fact that in Titan 100% were refractory versus 58%, but otherwise similar results in adenocarcinoma, again showing the difference in the populations, a very short time from diagnosis in Titan versus INTEREST, which probably had a lot of patients who had gotten chemoradiation, as well as had benefit from frontline chemotherapy. So again, very hard to show any particular biomarker of benefit in either of these studies. There was a suggestion of EGFR mutation as being better, and again, very similar to that of INTEREST. And again, the issue of crossover plays a big role in this. And PFS curves actually are much more instructive in this situation. So there was one hint of benefit in this, perhaps for chemotherapy and KRAS mutations. And these are certainly common in non-small cell lung cancer, and primarily seen in adenocarcinoma. They've been known about for a very long time now, probably 20+ years. And the predictors of poor response to the EGFR tyrosine kinase inhibitors is seen in this table over here. But perhaps, and it may be a little tough to see, is that, as was shown, perhaps some benefit for chemotherapy, and one always likes to look for this. However, I think that as we've seen, a lot of subgroup analysis, let us consider various issues of subgroup analysis, and subgroup-specific trial results and treatment should be evaluated with great caution. So this is a slide I took from the British Journal of Cancer in a paper by Peto recently, and the risk of false positive and negative results is extremely high. So this is not really a cancer study, but it's the ISIS-2 trial of aspirin versus placebo in patients with MI, as analyzed by your astrological sign. Now, as one can see, Libra or Gemini did not benefit. However, all other sides had a highly significant, with, 5 zeros after the decimal point before you hit the 1. And so I think that, one should take many of these subgroup analyses with a real grain of salt. So what are my observations and conclusions? I think, first, as we look at all of these studies, realize that this is the importance of clinicians and clinical trialists. Because remember that when we first started to analyze these agents, the thought was that actually EGFR would be, and TKIs would be better results in squamous carcinomas. They would be more important with chemotherapy than as single agents. And the understanding of the biology, the identification of mutations upon which many of our recent trials have been based, and upon which the actual use of these drugs, at least in first line, is heavily based, resulted from clinical experience with the drug, informing us of the biology, not the other way around. Clinical trialists are extremely relevant for the understanding of biology. Mutant patients should be offered EGFR TKIs early in the course of their disease, as first-line therapy if possible. And EGFR TKIs are a reasonable second and third-line option in good performance status patients with some evidence of prior benefit from prior treatment.
Thanks.
Let us recognize that no therapy is effective in chemotherapy refractory patients, period. This is an unmet need in a population that should be referred early for clinical trials, not late. Beware of subgroup analyses. The problem is probably in ourselves and not in our stars, and we need to be aware of that. And we need a reality check in advanced EGFR mutation non-small cell lung cancer. Few patients have truly durable benefit. We tend to regard these as the answers to our prayers in non-small cell lung cancer, but in fact, the median progression-free survival is about 9 to 12 months, a median overall survival of approximately 2.5 years. We still have a long way to go in this area, and we urgently need therapies for those patients who progress on these agents. Thank you very much for your attention.